This is Dr. Hooper. I'd like to thank you all for joining us. We're waiting a few more minutes. We'll wait 2 or 3 minutes before more join. I see quite a few are signing up or coming into the webinar right now, so give me a couple more minutes. I'm looking at the attendees and like to thank you all for joining us and for using Emma. I hope this helps you understand why we're doing this and how we do it. Again, this is Dr. Hooper. We're in my presentations. You can take notes and you can put questions into us. Our staff here will be taking the questions and giving them to me. And if I can answer them during the seminar or during the webinar, I'll do so. If not, we'll do them at the end. And we will also post the questions and answers at the end as well by, as I'm told, by a later date, probably 48 hours from now. I'll put this on mute for just a couple more minutes and then I'll come back on. Okay, this is new to me, so bear with me. Most of the time I record them and then they put them out in the following week. So this is new, and I'm expecting that I'll screw it up a couple times, but knock on wood that it won't happen. Again, we'd like to welcome those who have come on to our fourth webinar on the environmental samples and how we read them and then how we should understand them. You can go to our website under realtimelab.com and go in the environmental area, and you will see the teaching guidelines, and our 4 webinars are there that we have presented so far in the environmental. So with that being said, the other thing I pointed out when some of you first came on is that you can get questions submitted, and the questions will be given to our staff here, and then they will then give them to me, and we can hopefully answer them either on the slides that are being presented or at the very end. If we get so many questions that I fell on the floor writhing and screaming, we'll give those answers to you in the next 48 hours on our website as well. So with that, we'll start. And this is understanding Emma and the results of Emma and the comparisons made between the DNA results and mycotoxins. I'm a clinical consultant to Real Time Lab, and I hold an MD as well as a PhD. The goals of this webinar are that we're going to show results of case studies of homes that many of you have sent in that have ordered the EMA. We're going to talk specifically about things that many of you have called in and talked with either Dr. M or myself about, and that is mycotoxin positive results and the spore DNA counts being positive, mycotoxin positivity and no spore DNA found, or mycotoxin negative results and the spore DNA counts are positive. Mycotoxin negative results and spore DNA counts are negative as well. And when you know that, or you think that there's mold there, so that last one is important to pursue as well. All right, just to repeat what we've told you in the previous webinars, Emma, it's a girl's name of German origin, and it means universal. And it's right now ranked #1 on the popularity charts in naming babies. But Emma was my grandma's name, and that's true, it really was. And it's an easy name to remember, especially if your name is Emma. The real name stands for Environmental Mold and Mycotoxin Assay. What we did is we reviewed in our previous all of the ERMI organisms and how we came up with Emma. We then asked ourselves, what's the significance of all those ERMI organisms when we're reviewing pathogenicity or disease in humans? Too many organisms in the ERMI were just inundating to people. It caused confusion to the clinicians and the environmental inspectors when they were trying to explain just how important this DNA testing and organism testing is. So we decided to pick 10 of the most significant environmental organisms which can be pathogenic or disease-causing to humans and animal patients. Why do we need Emma? Well, the mold in a house isn't just a problem for people who've got allergies or asthma. The water leaks in the homes provide an ideal environment for mold growth. There are many mold species, especially Stachybotrys chartarum, and that is more dangerous than the most common indoor molds such as Aspergillus and Penicillium. However, in passing, I have read over the years in peer-reviewed literature only 2 papers that have shown that Stachybotrys chartarum is a pathogen, and they usually find it in either ears or nasal secretions. I have not seen any papers where chartarum is causing a problem in lung or skin as a pathogen. The reason that we look at it and the reason why the environmentalists are so intrigued by it is the toxins that Stachybotrys produces, which are called trichothecines. The last point on this slide is mold exposure can cause immunosuppression and upper respiratory infections. So the long-term exposure to mold can cause acute to chronic illnesses. And what we're finding out in some of our newer products, which we'll introduce at the end, in the clinical area, is that these environmental specimens can cause immunosuppression, and we're very concerned to those who have diabetes, who have lupus, who have cancer, and who have organ transplant. Those are just a few of the immunosuppressed diseases or situations. So we've given this slide before, the Emma versus ERMI. First of all, we're going to take each one of these tests and talk about them. The Emma tests for both molds and mycotoxins. ERMI only tests for mold. Emma tests only for clinically significant molds and mycotoxins. ERMI tests include molds with no clinical significance, as real-time lab and our medical staff can have ascertained so far. Emma, any spore count detected to us is significant. ERMI test scores can be misleading. And there's a literature paper that was introduced by EPA recently that said the test scores that go of 0 to 20 should not be used because they were for research use only. And EMA, again, is created for clinical association, and ERMI is created for research purpose only. The EMA test description that we're going to go through now is outlined here. It's a quantitative PCR, which we call qPCR procedure. It detects 10 pathogenic fungal species in environmental dust specimens. EMA includes 10 assays that meet the EPA standards. EMA is developed and validated by Real-Time Lab, and a manuscript is in preparation to publish these validations for EMA at the present time. So the components of EMA, or what is being tested for, and it's going to read from right to left, top to bottom, top, and then we'll go down across the bottom part. Again, the DNA of the 10 most common human pathogens, and this includes the newest organism, Candida RS, that we'll talk about in this presentation as well. There are 15 mycotoxins that we do. These are the most harmful mycotoxins discussed in peer-reviewed literature. The aflatoxins are, our antibodies cover B1, which is the most carcinogenic. There's B2, G1, and G2. In our discussion of mycotoxins, we talk about the families, and each of these structures are just like kids or husbands and wives. So aflatoxin is the family name, and B1 is the dad's name, etc. So you have to realize that these are different structures. Ochratoxin A, very important. One of the things I have seen in discussing why should we not send to real-time anymore is ochratoxin A is not sensitive. Real-time labs cannot pick up as many ochratoxins, and it's not as sensitive, which is absolutely incorrect. The paper we wrote in 2009 was our validations of specimens that patients sent in and that we also have had received at that time, which were quite a few less than we do right now. But we did a very good validation, and we were honest in our validations of ochratoxin A. We said our sensitivity and specificity were much lower in ochratoxin A at that time. In our new validations, you will see our sensitivity and specificity is much greater. People are saying, oh, Real-Time Lab only has a 17.4% sensitivity and specificity is low as well. That is absolutely not true. And we will definitely be presenting that in our paper. The macrocyclic trichothecenes are the other area of Stachybotrys. Macrocyclics are the group Ds, and there are A, B, C, and D. A is T2, and then if you look at the other trichothecenes, macrocyclics are the ones that are extremely dangerous and are, to my knowledge and to my review in literature, very infrequently found in food, if they're found in food at all. So to say that you found a macrocyclic trichothecene to Real-Time Lab and our results means you have found a trichothecene that is only involved in respiratory illness. Gliotoxin is the last group that or the family that we test for, and gliotoxin is produced by Aspergillus fumigatus and other aspergilli, and it's very important in immunosuppression. The EMA reported is now done in a fungal load. And the reason that I did this is, we'll discuss this in a minute. Fungal load units are in nanograms per mil or micrograms per mil of fungal DNA per milliliter. It's a term that Real-Time Lab uses and will continue to use when discussing fungal infestation and possible infection in the patient and his or her environment. Why do we use the term fungal load? Well, without treatment in a body, a virus, a fungus, or a bacteria can replicate, and they can make copies of itself, and they can increase the amount of the, in this case, fungus in the body, and it goes unchecked. Usually it grows and makes mycotoxins. The results have in the past been reported in spores per milligram of dust, which may or may not be misleading to you, because when you compare that to the mycotoxins, it's very difficult to draw any correlations. Validations and associations with human illness has been very difficult to interpret then when you look at just spores per milligram. So the fungal load is a measurement of how much fungal DNA is present in a sample. And you can read more about this on the point that I put down here on the bottom of the slide. But let's go back just a minute to something that you may or may not be associated or heard about. But the reason we call it fungal load is the same as calling it a viral load. When HIV and hepatitis were first being looked at, they could screen them okay, but they couldn't tell if the drug of choice or the treatment was being useful to these unfortunate patients. So what they started to do is look at viral load. And when you treat a patient with hepatitis or HIV, you always are drawing blood, looking for how much virus is in the sample. And then they call that the viral load. If the viral load goes down, then the treatment is ascertained to be working well. If the viral load continues to go up, then that's a problem. So we can talk about viral load, fungal load, bacterial load, and so we adopted the term fungal load. The fungal load is really the limit of detection, or the LOD. All fungal load tests have a cutoff point below which they can't reliably detect fungi. So how did we come up with this? Well, we grew the organisms, the 10 organisms that we have on our test. We grew it in liquid media, and when it was growing and had spores, we removed the spores in 1/10 of a cc, for just an example. And we diluted those out so we could count the spores in a specific amount, 1/10 of a cc. And so say we got 5 spores in a cc or in a milliliter. Then we handed that off to our technologists who were doing the DNA, and we extracted those 5 spores, and we said, oh, we get X amount of DNA per spore. And that's how we came up with that list. So just because the level of mycotoxin and fungus now is too low to be measured doesn't mean that all these organisms have disappeared. It's just below our level of detection. So the patient and the inspectors must be vigilant in their pursuit of ridding their body and the environment they live in of the molds and the mycotoxins. So we put out this letter that comes with all of your results for Emma, and it's called Fungal Load Readings. The letter that you've got in the past had a percentage or a decimal number. We have decided that we have rounded off these numbers. So let's take an Aspergillus fumigatus. We know that 1 nanogram of detected DNA per milliliter sample is an average equivalent to the following number of spores per milliliter. So if I give you a result of a 1/2 nanogram of DNA, then we have a half of 11, which is what, 5.5. 5.5 spores per milliliter to us is significant, especially when you're looking at immunocompromised patients. This is not the same as the ERMI results at all, so you can't draw any conclusions with that. But you can see that we are measuring actual DNA of the sample. The very bottom, we detect Candida RS as well. And again, Candida RS doesn't have any spores, but 1 nanogram of detected DNA per milliliter of sample is equivalent to the following number of colonies forming units per mil. And that is a very small amount of colony forming units, but it doesn't take a lot, as we're finding out in the literature, to make an individual ill in this environmental organism. Our mycotoxin reports are reported in parts per billion or nanograms per deciliter. Keep that in mind, because a lot of people will say, oh, we're more sensitive than parts per billion. If we're doing this test, we're in picograms. Well, picograms, very, very small. That's true. So they are more sensitive. But let me ask a question as to why would you want to know the smallest amount there that's detected when the environmental people, the FDA, the USDA, report everything in parts per billion or nanograms per deciliter? So we use something that's very closely tied to what the government regulations are, and that is the FDA and USDA. Each mycotoxin group has been validated here at real time to be reported in parts per billion. And again, I've emphasized which is well accepted in peer-reviewed literature, as well as the USDA and the FDA. So now we're going to talk about these correlation case studies. The first one is a drywall sample. And yes, people do send us pieces of drywall. The top part of these next few slides are the areas of mycotoxins first, and then down below is the DNA or qPCR and how they correlate. Okay, the first result of the mycotoxin, ochratoxin A, was present at a value of 15.2 parts per billion. Aflatoxin was not present in our ELISA test. Trichothecene group, again, there's 9 of these kids or children there, was present in that family, and that was high at 2.97 parts per billion. Gliotoxin was not detected. So when we did the EMA, all of our results correlated with the drywall, especially when you look at Stachybotrys. We had 22.3 spores, or 22.3 nanograms per milliliter, it's 22.3 nanograms per deciliter of DNA in Stachybotrys. Well, when you multiply that out using our chart, it was a large number of Stachybotrys spores. Keeping in mind that in the drywall sample, if you give us drywall and you want us to sample the front part, or you only send us pieces of drywall with paint on it, Stachy hates that. They won't grow on it, but they will grow on the back part of the drywall because there's nothing there other than cellulose and water. It has to have those two components. Stachy usually travels with its best friend, chetomium, and this again had chetomium present. We have elected not to add ketoglobosum to our studies and to our environmental studies with mycotoxins, but the takeaway here is that Stachybotrys was found in high levels of trichothecenes, so it correlated. Now, people are going to say, yes, but you have found ochratoxin. Why didn't you find an organism that produced that? Because we don't test for penicillin. Remember that we brought Emma up in our validations because we're looking for the organisms that usually cause disease in patients. And penicillium is rare, can do that, but not as important as these. Stachybotrys, again, I need to emphasize it is not a, quote, real pathogen to the humans, but that trichothecene is torturous to us. Everything else is very pathogenic here. The next case, Emma correlation between AC filters, air conditioner filters. We found in the mycotoxins that there were no ochratoxins that we could detect. We couldn't detect AFLA, but we could detect the macrocyclic trichothecenes, and we definitely could found the gliotoxin. And when you look down on our qPCR, we found Aspergillus fumigatus, which makes gliotoxin. We found Niger, Aspergillus niger, that can make the gliotoxin as well. We found Aspergillus ochraceus, but we didn't find gliotoxin or ochratoxin. Well, perhaps it can be found somewhere else, but we didn't find it in this submitted specimen. So take home here is that this AC filter that we tested for had significant amount of gliotoxin and Aspergillus, and the Aspergillus needs to be found. The site of the water leak or the problem in the house needs to be looked at. Next case, we also accept swabs here, and the other area that we do accept now is these sterile gauze that you can use, and we like to get a 3 by 3 inch gauze, and you can use them like a dust rag. Should not be anything on them like Swiffers have with chemicals, and they're not so big as Swiffers either, because Swiffers, how do you extract all the stuff off a Swiffer? Unless you put it in a gallon of PBS or phosphate buffered saline or something. I'm sure groups will say, oh, we can do that without any problem, but I'd like to see that. Again, ochratoxin A is not present, AFLA was not present, trichothecenes were not present, but lo and behold, gliotoxin had something we could not detect a small amount. We detected something greater than 50 parts per billion. And when you looked at the DNA, we found 906 nanograms of DNA, which comes to a huge number of spores if you want to correlate that out. But again, we're trying to get you to think in DNA per milliliter and not numbers of spores. Again, there were other organisms found like Ketoglobosum and Stachybotrys, but they were in small enough numbers and they were probably overtaken by the Aspergillus and not being allowed to make mycotoxins. We cannot explain why we couldn't find it, but one of the things we can explain is you got to get rid of the Aspergillus. Something of note is that Fusarium solani was found in high numbers as well. Fusarium solani is very important to us in the clinical area because if you can remember years ago, there was a recall of Bausch and Lomb contact lens solution, and it had huge numbers of fusarium present, and it caused fungal infections in the eye, and some people lost their eyesight and the iris of their eye. So very important for us to note whether or not that's due to a mycotoxin or the organism itself is a moot point to us. We have not seen where a mycotoxin from Fusarium can cause clinical evidence in disease, but we do know that Fusarium solani can cause significant problems itself by just growing. Okay, so now here's the other problem that we get into when we talk with you about the mycotoxins and DNA correlation. First of all, mycotoxin is detected, but we have no DNA found. Well, the mold is causing the mycotoxin, possibly, that's not in the EMA panel, i.e. penicillium. The number of low organisms could be present, and hence the low or no DNA, which may be producing a detectable amount of mycotoxins. The mold could be dormant, but circulating mycotoxins were released earlier, and mycotoxins are highly stable in low and very high temperatures. Here we did validation studies and found that they could exist as high as 150 degrees Fahrenheit. And when you look in the chemical manuals, you can see that these structures are very stable at high and very low temperatures. Again, there may be low moisture and low humidity for mold growth, but the mold is growing, even in small amounts, and it can be producing mycotoxins, which we then can detect. There are volatile organic compounds, which many of you know about, produced by other organisms like bacteria and viruses, or not viruses, bacteria and maybe molds, which can inhibit mold growth at the time of sampling. So the whole take-home lesson here is, since both mycotoxins and DNA are conducted in the EMA testing, we're covering all fields now, it can be ascertained that there's a problem in the environmental situation, since one or both components are determined. So you're hedging your bet by looking at mycotoxin and DNA. If you find anything in either one of them, it's bad. Okay, the next slide says mycotoxins are not detected, but we found DNA. Well, we've found in our evaluation that this could be a sampling issue. That's why our sampling issue is always changing and trying to comply with your needs out in the field. So we've developed composites where you can send in one sample or 3 samples, and we can combine them as one sample to help you in cost. The composite may be, who knows, it could be having an inhibitory substance on it, or we didn't get enough dust. The dust that we get frequently could be coming from areas that were cleaned already. And surprisingly, we do get samples that the AC filters were new or they were recently cleaned, and people were saying, how come we didn't find anything? We just know there's mold in here. Well, that could be why. So when we start talking to them, we find out a little bit more. There's another example of sticky molds, and many of you in the environmental industry know about this. Stachybotrys is the most prominent one that we can talk about. It really can settle on porous material, and they don't float on dust easily. They're heavy, sticky, and they're very difficult to find in the dust, but we can find them. Whereas the mycotoxins are low molecular weight and they can float on the dust and can actually, there's papers that show this, that they can be seen being collected that come through the electrical sockets. I remember a individual who I respect very much from the University of Texas in Lubbock, and Dr. David Strauss told me that years ago, that be very careful if you are looking for this, because it could be on the back of the wall, and these mycotoxins could be coming through these areas of the light switches or the electrical sockets. Okay, mycotoxin is not part of the EMA is another reason, like ketoglobosum A. Even though you find chetomium in our DNA, we don't find ketoglobosum because we don't do it. But it's taking home the same lesson as before, as will go at the bottom. At present, the molds that are found are positive DNA, but they're not being metabolizing mycotoxins, as they may not be threatened by their environment. So you would find DNA, but you might not find mycotoxins in levels that we need or that we can know that will cause problems in the patients. The thing to remember when you're talking with your clients or your patients or whatever, the mycotoxins are secondary metabolites. They're only made by these organisms if they need to be made for being threatening, or they need food, so they got to kill off sources so they can have that energy source. The take-home lesson again, since both mycotoxins and DNA are conducted in the EMA testing, it can be ascertained that there is a problem in the environmental situation since one or both components are determined. So again, you're hedging your bet. Okay, Candida RS is the most resistant organism found in the hospital environment to date. This is a new organism. Well, it's not a new one. God made it years ago, but we have just been alerted that this is a problem. Here is our environmental mycotoxin test. Ochre was not present. Afla was not present. Trichos were not present. Glio not present. Oh, this is a clean house. Why did we even bother with it? But when we did the EMA, if you look down the list, we found Candida RS, even in small amounts of nanograms of DNA per milliliter. Very important to understand that this Candida RS is resistant to many antifungals, and we will be putting out more and more literature as CDC lets it be known as well. We have found it in one tissue so far, and we are anticipating getting this as a case report. We've alerted CDC that we found it, and we're interested in looking at more of the environment where this came from. Again, Candida RS is a drug-resistant germ, and they say germ. This is from CDC, and this is for the masses of people that read this stuff. And it spreads in healthcare facilities, but we're finding it. We found it in one so far in a house in the environment. Candida RS is a fungus it's a yeast that causes serious infections. It's patients with this infection, their family members and other close contacts, public health officials, laboratory staff, and healthcare workers can all help stop it from spreading. That includes you guys. Why is it a problem? It causes serious infections. It's often resistant to many of the medications and the antifungals. It's becoming more common. I don't know if that's true. I think it's always possibly been there, but the detection of that was very low. It's difficult to identify in the clinical laboratory. And if you put it on different medias in the clinical lab, it looks just like any other yeast. However, if you put it on colored medias or medias that can force it to use different sugars or assimilate sugars, it causes a different color. But still, clinical labs or environmental labs were not used to looking at that. Well, we do the DNA, so it's not hard for us to find it. And it can spread in hospitals and nursing homes, and as you guys will start seeing, it can spread in environmental houses with problems. Here's the tracking that Candida RS has seen so far by CDC. This is a recent map, and you can see that our home state of Texas is very involved with this organism. The biggest states, Illinois and New York, with that. Well, they're not the biggest states, but they're the states that have the biggest amount of Candida RS reported so far. I'm sure this will increase, but there's over 500 isolates now that have been found through tracking by CDC. 1 year ago, we asked CDC if they could give us some of their isolates to use against our DNA, and we got those isolates, and we got approximately 35, and we did those testing, and every one of the Candida RS that they got cross-reacted with our DNA probes and primers. The last slide that we have to present today is the clinical useful measures for this Candida and the Aspergillus species. We have come up with an early and rapid detection of invasive candidiasis in human body fluids, and we are able to look at this in blood samples. And you probably think, well, everybody can look for Candida in blood. Not really, because Candida is very difficult to find in blood unless you do a blood culture, and that includes Candida RS. So if you take a blood sample and you put it in a blood culture, the amount of time may take 3 to 5 days for it to become positive, or as the lab or docs call it, pop positive. And then it takes another 24 to 48 hours to identify it. And so now the patient's been in the hospital for 5 to 7 days and is on an antifungal that may be not useful. The same is with Aspergillus. However, Aspergillus won't grow in blood. It will only grow on media. And so we decided to make a DNA probe for this, as other clinical labs like LabCorp, Quest, and other research labs have. However, ours is a dual amplification, where we take the sample and we, in layman's terms, we double amplify it so we can find even the smallest amount of Candida and Aspergillus in the blood. And so we can find it in less than 6 to 12 hours after the patient gives us the blood sample. And so we're getting these samples from all over the country. We're doing a multi-hospital study with large universities and university hospitals in the areas of transplant and cancer, and we will be reporting those out very soon. So the questions probably are many. Again, we're real-time labs. We're located in Carrollton, Texas. We have multiple sites where you can read about us on our real-time lab website. We have Facebook, and we have Twitter, and you can see Mold Critter down there. He's a mean little bugger. He's very small, but he can be mean. So with that, we're going to answer some of the questions now. One of the questions you asked is, why did you not include chetomium in the, I assume you mean in the ketoglobosum study? And that's because our system of ELISA, we didn't feel could detect ketoglobosum in the level of detection necessary to be clinically relevant. Again, you could use other methods, but we figured if you find chetomium in any manner, you need to get rid of it. The next question, in a healthy individual, what is the level of concern? It is real-time's position that, and I assume you're talking about mycotoxins again, that any mycotoxins in a patient is a level of concern. There is nothing in the peer-reviewed literature that says that there is a safe level of mycotoxins. We are all developed to take care of toxic challenges in the environment that can be taken care of and got rid of. Most of the time, all of us who are healthy have systems available that can handle the mycotoxins. Either they excrete them in the stools, or we can get rid of them in some way. But those of us who are challenged with high levels or through an environmental system, or our immune suppression is bad, we start seeing them in the urine. I would like to say that, gee, we find mycotoxins in every patient, because then we'd be able to determine, well, there is a healthy individual level, but there are approximately 55 to 60% of our patients have nothing, no mycotoxins at all. Only about 40% of the patients that come in who are being seen by clinicians are positive for mycotoxins. So that's the reason that we say what we do about the mycotoxins. I don't see any more questions right now. If there are further questions in the future, you can certainly, oh, here's an answer. But a healthy person could start to become affected over time, absorbing too much. That may be true, depending on what the level of insult, I call them, in the environment could be. So that's up to the environmental people to find these things and get rid of them before this healthy person becomes too difficult to handle by the clinicians. The whole thing to me is you're looking at a multi-organ system in a human, and you're looking at maybe a two-dimensional system in a house, but the multi-organ system in the patient has so many things to be considered. What's the insult coming from the environment? Then how is a normal person handling this? And then the last thing is his genetics capability able to handle such a insult as we're seeing coming from this environment? Hence, we have gone to looking at a nutritional genetic analysis in some of these patients, well, any patient that wants it. And you can read about that on our website called INGA, I-N-G-A. Again, Emma, my grandma's name, Inga, my grandma's sister's name. So there's another question. What other mycotoxins, let's see, other than mycotoxins, what else in mold can make one sick? The surface of the mold spore and the surface of the mold septae have components, sugar components called glucans. And so when you're looking at a patient in a hospital, a lot of docs use looking at a beta-glucan serum test, or they looked at something called galactomannan. And these tests are FDA approved. However, they are not as sensitive as what clinicians like to do. Plus, they're very expensive to find. But those components are very important when you're looking at a very ill patient to see, is there galactomannan or their beta-D-glucan positive. Another question is, how do you recommend professionals protect themselves from mycotoxins during the course of their work? And now, doctors are used to wearing white coats and gloves when they examine patients. However, then they go from room to room and don't change their coats. So I don't know about that. But the people who are working under the houses or doing these investigations of houses, you cannot think of these as safe products in what you're doing, or safe areas. You don't know what you're going to run into. So I talk about using gloves, mask, have the proper set of equipment that you wear. And only those of you who have worked in this a long time know more about that than I do. But I'm telling you, I wouldn't go under a house or go into a house, even if they asked me, oh, there's nothing wrong with my house, without having the right protective clothing. Now, we can do a seminar or a webinar on that, but I need some help in looking at that through many of you environmental experts as to how you would suggest doing this. These mycotoxins are not something you should poo-poo, as some of the allergists will do. These are important. They are very deadly, and they are something to be strictly concerned about. Next question is, what recommendations have you seen being set in protocols for the removal of mycotoxins from surfaces throughout the home? Interesting that many people have given, they say, oh, we have solutions to this. We have a candle, or we have a spray, or oh, just use Clorox or something to clean these out. And however, when you read the literature, there's nothing. There's no written peer-reviewed literature to say, I had X amount of mycotoxins on a sample, I used this solution, and then I tested it over a period of time, like a 3-month, 6-month, 9-month sample. And so I don't know how you guys can say what you do about this, because even if you go back and sample again and we tell you it's clean, how long are you telling them it's good for? So we are testing some reagents in our laboratory right now that are nearing the year-long end of these protocols. And I'm telling you, there's a couple. There's one specifically that I really like, and I'm looking forward to publishing that as soon as we finish that study. But once that substance is on the contaminated area, we have found no reoccurrence of mycotoxins at all. We haven't done the EMA PCR on that, but we have done the mycotoxins. Next question is, how do you sample when mold is in the air? Let's see, how do we put this? How do you sample when mold in the air is not continuous? Not sure why in different areas when there may be a low-level exposure. Had an air test done, not sure. I think I'm going to hold off on that one and answer that over the web, because that's a long multi-question. So I'm being told that my end is near, not my end, but the end of the webinar is near. So there are many questions coming in now, and I promise we will answer them and put them on the website for you to review. Feel free to call in to us and give us your feedback, please, because we're here to help you and your clients. And if we don't hear from you to improve, we can't do anything more, but just sit here and pat ourselves on the back saying, gee, we're pretty good. So thank you again for listening. Thank you again for putting your questions out, and we look forward to more seminars. Thank you.